Am I audible, sir?
Yeah, you are audible. Yes. Start.
Shall I start?
Absolutely, yeah.
I'm Leslie from Lakeshore Hospital. Today I'm going to present Polarix trial. Paltusumab vedotin in previously untreated diffuse large B-cell lymphoma. DLBCL is the most common form of lymphoma. 40% of the patients treated with R-CHOP will have either refractory disease or relapse after initial response. Numerous approaches have been attempted to improve the outcome, but none has shown any meaningful improvement till now, and R-CHOP remains the standard first line. Several novel agents have been tried in combination with R-CHOP prior to paltusumab, mainly bortezomib, lenalidomide, and ibrutinib, and none has showed any OS benefit. And intensified chemotherapy regimens like 2-weekly R-CHOP and dose-intensified R-Ampok has also been tried, but it has shown no OS benefit. And novel anti-CD20 antibody like obinutuzumab was combined with rituximab along with R-CHOP, and it has also showed no significant OS benefit till now. Paltusumab vedotin is an antibody drug conjugate, which is linked to a protease cleavable linker to monomethyl orostatin E. It is directed against the CD79B receptor, which is ubiquitously expressed on the all cell lymphomas. Binding of the drug to the CD79B receptor causes internalization of the drug and finally cleavage by proteasome enzymes and releasing MMAE, which is a potent microtubule inhibitor causing cell death. CD79B is a subunit heterodimer transmembrane component of the B-cell antigen receptor. It is involved in cell signaling. It is ubiquitously expressed on the mature B cells. And paltusumab vedotin is an antibody drug conjugate with anti-CD79B monoclonal antibody conjugated by a protease cleavable linker to monomethyl orostatin E, which is a potent microtubule inhibitor. It has shown activity in relapsed DLBCL with an objective response rate of 52% as a single agent. Paltusumab in combination with the bendamustine and rituximab in relapsed DLBCL has improved overall survival when compared to bendamustine and rituximab alone in relapsed DLBCL. Now coming to Polarix trial, it is a multi-center double-blind placebo-controlled phase 3 trial in which patients of age group 18 to 80 years with previously untreated DLBCL with IPS score of 2 to 5 and ECOG performance status of 0 to 2 are randomized in the 1:1 ratio to paltusumab vedotin plus R-CHP plus vincristine placebo and R-CHOP group with the paltusumab vedotin placebo. After 6 cycles, all patients received cycle 7 and 8 with a single agent rituximab. Primary endpoint of this study was investigator-assessed progression-free survival, and secondary endpoints were event-free survival, complete response rate at the end of the treatment, DFS, OS, and safety. Baseline characteristics were well matched between the two groups. Median age group in this study was about 60 years, and more than 80% of the population in both the groups were of stage 3, stage 4 disease, and double hit population was below 10% in both the groups, and 1/3 of the population was of ABC subtype. and IPI score 3 to 5 in 62% of the population in both the groups. The CT or PET-CT was planned after the end of the treatment and during surveillance, that is every 6 months for next 24 months, then every 12 months for next 36 months. 1,063 patients were assessed for eligibility, out of which 879 underwent randomization, 442 Paula RCHP group and 439 to RCHOP. Out of 414 Paula RCHP, 387 completed treatment, 374 remained in the trial follow-up, and 66 discontinued the trial. And out of 439 in the RCHOP, 377 completed treatment, and 363 remained in the trial follow-up, and 76 discontinued the trial. Treatment exposure, CNS prophylaxis was given in 16.4% of the population in paltusumab group and 19% of the population in RCHOP. And all 6 cycles were completed by 91% of the patients in the paltusumab group and 88% in the RCHOP group. And all 8 cycles were completed by 88% in the Paula RCHP and 85% in the RCHOP group. Objective response rate comparison between Paula RCHP and RCHOP. Complete response rate was shown in 78% of the population in the paltusumab vedotin and 74% of the population in RCHOP group, and partial response in 7.5% in the paltusumab group and 9.8% in the RCHOP group, and stable disease in 1.8% of the population in Paula RCHP and 1.4% in the RCHOP. Primary endpoint was progression-free survival. At the time of data cutoff, median follow-up was 28.2 months. Risk of progression, relapse, or death was significantly lower in the paltusumab group, and percentage of patients surviving without progression at 2 years was 6.5% higher in the paltusumab group compared to RCHOP. This is the graph showing progression-free survival with a hazard ratio of 0.73 with a significant PFS benefit in the Paula RCHP compared to RCHOP. Event-free survival was also significantly better in the Paula RCHP group compared to RCHOP with a hazard ratio of 0.75. Investigator-assessed disease-free survival was also significantly higher in Paula RCHP compared to RCHOP with a hazard ratio of relapse or death 0.70, but there was no significant overall survival benefit with Paula RCHP when compared to RCHOP. At the time of data cutoff, 22.5% of the population in the paltusumab group had received more than one subsequent line of treatment, and 30.3% of the patients in the RCHOP had received more than one subsequent line of treatment that was not specified in the protocol. Stem cell transplant was used in 3.9% of the population in paltusumab and 7% in the RCHOP, and CAR T-cell therapy in 2% of the population as a subsequent line of therapy in paltusumab group and 3% in 3.6% in RCHOP. This is the forest plot showing subgroup analysis of PFS in patients aged more than 60 years, IPS score 3 to 5, and ABC type of DLBCL has shown significant PFS benefit with the Paula RCHP compared to RCHOP. Adverse event comparison between paltusumab vedotin plus RCHP and versus RCHOP. Main adverse event was peripheral neuropathy in 52.9% of the patients in the Paula RCHP and 53.9% in the RCHOP group. Diarrhea was significantly high, was slightly higher in the Paula RCHP compared to RCHOP, and febrile neutropenia was also higher, 14.3. In Paula RCHP compared to 7% in the RCHOP. Grade 3 or more adverse events was comparable between paltusumab vedotin and RCHOP group, 60.7 in Paula group and 59% in the RCHOP group. And serious adverse event, grade 5 adverse event was 3% in Polar group and 2.3 in the Archop group. These events were primarily related to infections, pneumonia in 4 patients and 3 patients respectively, and sepsis in 1 patient and 3 patients respectively. Polar RCHP showed a significant PFS benefit over Archop mainly in ABC like DLBCL and high IPS score of 3 to 5. And Polar RCHP resulted in a risk of disease progression, relapse, or death, which 27% lower compared to Archop. PFS at 2 years was 76.7% versus 70.2%. Event-free survival was significantly higher with Polar RCHP than with Archop. The percentage of patients who had a complete response did not differ significantly between the two groups. Remissions appeared to be more durable with the Polar RCHP than with Archop. The median follow-up in this trial was 28.2 months, which was not high enough to observe any significant effect of PFS on OS. Other studies had indicated that PFS and 2 years event-free survival are often surrogate markers for OS in patients with the DLBCL. The lack of significant difference the lack of significant difference between a group and OS in this may also be explained by the advent of new effective treatments for relapsed or refractory DLBCL. DLBCL is characterized by an early relapse followed by a distant plateau in survival curve, indicating high probability of cure. Late relapses are unusual. This trial do not yet confirm that remission with Polar RCHP will be durable. It can be confirmed with only longer follow-up. Drug delivery was not impeded by the replacement of vincristine with the paltusumab. Fewer patients in the Polar group had adverse events that lead to the discontinuation of the drug or dose reduction. Peripheral neuropathy is expected in patients treated with the antibody drug conjugate containing MMAE. Majority of the peripheral neuropathy in this study was grade 1. Grade 2 or higher was reported in 13.8% in the paltusumab group and 16.7% in the Archop. Incidence and severity of peripheral neuropathy was similar in both the groups. Febrile neutropenia was higher, 14.3% in the paltusumab group compared to Archop, but it didn't translate into a higher overall incidence of infection, treatment discontinuation, or dose reduction. Limitations of this study, PET-adapted approach was not used. No autologous stem cell transplant was used in patients who did not achieve a response. Giving R-CHOP as a standard of care in double hit is not a standard practice, and longer follow-up is needed to comment on the overall survival benefit. This trial was not powered or designed to compare the PFS in patient subgroups. The observed heterogeneity in the treatment of Polar RCHP across various subgroups need to be assessed in future trials. Thank you.
Thank you, Dr. Nasneen. I think you've thrown light. I think the limitations also been explained well. I'll just leave it to examiners, Dr. Sunu, Dr. Shaufij. Any questions or opinions? Was the journal clear to you, and would this change your, practice per se? Any questions also?
I don't just
Doctor.
one thing. Yeah,
Yeah.
I need to ask him.
Yes.
The incidence of neutropenia was very high, febrile neutropenia. This is a monoclonal antibody, and what could be the reason for that increased incidence of febrile neutropenia? Any idea?
The antibody can be the reason. We have a chemotherapy monoclonal antibody. That may be.
Pardon?
It's an antibody drug conjugate, right, sir? ADC. So that drug as well as
that would have contributed to that. Okay.
Actually, the incidence of febrile neutropenia is 14% versus 8%, if I remember. But I think our incidence of febrile neutropenia is much higher, right? I think 25% would be Ampok febrile neutropenia in the population, means at least I treat. That's why we give prophylactic, PEG GCSF for all our patients. So I thought the rates were actually lesser than what we normally see, at least what I have seen
No.
in practice.
But what was done, nothing has come to beat CHOP or RCHOP till now. So everything else has been playing around RCHOP. Still RCHOP is continues to be the standard. But then the subset analysis, as she mentioned, the double hit lymphomas, this was the RCHOP is not the standard. So the subgroup was not included. That's what I remember, if I'm able to recollect from the study.
One last question, if like how is this injection given as an infusion, just like rituximab or IV bolus, Dr. Nazneen? Is it been mentioned how this is administered? Dr. Nazneen?
And first cycle we give 90-minute infusion, and subsequent cycles we give 30 minutes infusion, and we have to pre-medicate with the antihistamines and acetaminophen for hypersensitivity.
Okay. Dr. Shafiq, any other questions?
No, I think the company is yet to launch in India, right? Colartismol is coming up in India, right?
No, it's
How
not.
much is
It's
the
not.
cost? No, they are coming up, I think. They are about to launch, that's what they told, I don't know. I think Roche is manufacturing this, right? Colartismol?
I'm not sure about that detail.
I
But,
think they're about to launch in India.
Yeah, it's a Roche product. They're yet to launch next year.
Yeah.
Hopefully, the drug will be launched in India. That's what I came to know.
Yeah.
Hmm.
So I think it will not replace RCHOP. More studies are needed, I guess. Maybe
Yeah.
like ABC subtype, high IPA, those subsets may benefit. We don't know. We need more experience from our side. That's what I feel.
True, and also I think it's approved in the relapse setting, no? So maybe that's why the overall survival, if you use this drug in second line, maybe the overall survival will be same as using it in the first line. We can't be sure. Anyway, thank you, Dr. Nazneen. I think we'll move on to the case presentation. Dr. Sunu is here as well, right?
Yes, yeah, I'm here.
Okay, sure, okay. Okay, I'll invite Dr. Ashwin to take over the proceedings and give the case presentation. And yeah, I'll hand it over to the examiners to carry it forward. Dr. Sunu, just opening words, just start.
Yes. Thanks to Boban and Arun for inviting us to be the examiners for this. And welcome Ashwin Joy. You're the final year DNB in medical oncology from MVR Cancer Center, Calicut. So I think you're going to present a case on a lymphoma, broadly as a lymphoma, or I think a patient with a lymphadenopathy. So Shafiq, you can mention some.
Yeah. Yes, sir.
Sir, is it visible?
Yes.
Yes. Good evening. I'm Dr. Ashwin. I'm a DNB resident at MVR Cancer Center. Today I'm presenting a case of lymphoma. Now this is Mr. Prabhakaran. He is a 53-year-old male hailing from Ponnani, Malappuram, coming from a middle-income family. He studied up to high school. He's a tailor by profession, and history has been obtained from the patient, and it is reliable. The chief presenting complaints were a swelling over the left side of the neck for 2 months duration and swelling in both the groin regions for around 1 month duration. He also complains of loss of weight and associated loss of appetite. Now coming to the history of presenting illness, he was apparently normal 2 months back. He noticed a swelling on the left side of his neck, which was insidious in onset, which was painless and was progressively increasing in size. Shortly afterwards, multiple similar swellings appeared on both the sides of the neck, and which did not cause much discomfort and were enlarging. And there were no local symptoms like history of nasal obstruction, epistaxis, swelling in the oral cavity, or any dysphagia. And around after 1 month, he noticed a similar swelling over both the groin region, which was progressively enlarging and which was easily felt through the clothing. And that too had no history of any discharge or fungation of the node, and there was no genital ulcers present. He reports that he has an unintentional loss of weight of around 5 kilograms over the past 1 month. And there is no history of any fever, drenching night sweats, or excessive fatigue reported by the patient. There is no history of any bleeding manifestations, gum bleeding, blood transfusions, no history of any decreased urine output, pale edema, palpitations, chest pain, no history of cough, dyspnea, facial puffiness associated with any arm swelling. There was no history of headache, confusion, seizure, or blurring of vision, no history of any pruritus, yellowish discoloration of sclera and urine, and no history of any abdominal pain and any distension, upper quadrant pain, and no history of back pain, bone pain, paresthesia, and lower limb weakness. He also does not report any history, prior history of joint pain, stiffness, rash, or any recurrent infections. Now, coming to the past history, he has had no history of any similar complaints in the past. And he is diabetic for the past 10 years, well controlled on OHA, and has no other comorbid illnesses. There is no history of any chronic drug or drug allergies, and he has no history of any prior ATT treatment, and no prior surgeries or no prior history of received of anti-cancer treatment. And personal history, he is a non-smoker. He's not an alcoholic. He takes a mixed diet. Bowel habits and bladder habits are normal. There is no history of any sexual promiscuity or no history of any occupational exposure to carcinogens. Now, coming to the family history, there is no significant history of any malignancy in the family. Now, coming to the
Ashwin,
yes, sir.
I think there's some background.
Yes, sir.
Ashwin, can you hear
Yes,
me?
sir. Yes, yes, sir. Yes, sir.
Can you please go a few slides back? One more. Yes. So from the history, what do you feel like you're going to deal with?
Sir, this is a middle-aged man presenting with progressively enlarging swellings, and it is rapidly enlarging, and new swellings are, he has new swellings elsewhere in the body, and it is associated with a significant loss of weight also. And so we feel that it is a malignancy, and because it has 2 months duration and there is loss of weight, and it's a progressively enlarging swelling, and new swellings are appearing, and it's likely to be a lymphoma.
Okay. Now, yes,
no other
Shafish,
disease?
please.
No other disease from the history? Apart
The
from
history, it's unlikely to be a leukemia because he gives a history of around 2 months, and he is well preserved and he's not sick, and there is no history of any recurrent infection, fever, or any bleeding tendencies. And
how can you say he's well preserved based upon the history?
yes, sir, I can comment that on.
That will be based upon examination, right? How
Yes,
can
sir,
you
yes, sir.
determine this patient is well preserved from the history?
He doesn't give any signs of excessive fatigue or unable to do his routine activities.
Okay.
Okay. Now we know we are dealing with some oncological condition because we are an oncology group. But to start from the basics, what would be the other deities apart from oncology that you would put in one sentence, like 1 or 2 points?
Sir, basically, I would also consider infections. This could be like HIV, which can present with generalized lymphadenopathy, latent phase, persistent generalized lymphadenopathy. And it can be other viral infections like glandular fever, mononucleosis. It can be other bacterial infections. It can be collagen vascular diseases like lupus.
That's likely to be. Yeah.
TB won't come to your TB, man. In India.
Sir, tuberculosis, sir, tuberculosis.
Yeah, that should be the most important. The generalized
don't consider-
lymphadenopathy might be quite rare.
With loss of weight, you wouldn't put the previous second DD.
No. Yes, sir. Tuberculosis, and it can present with generalized lymphadenopathy if it is a primary infection, or if it is in an immunocompromised person, it can present with extrapulmonary manifestations.
So from the history, suppose we are going to deal about lymphoma. What kind of a lymphoma does it look like from the history?
So from the history, I feel that the involvement, based on the involvement, it is a non-contiguous group of lymph nodes are involved. Like the cervical lymph nodes are involved, then the groin swellings are there. So it's more likely to favor a non-Hodgkin's, and the age of the patient is also around 53 years. Hodgkin's lymphoma would be more common in a younger adult. So I would consider probable diagnosis of a non-Hodgkin's lymphoma and an aggressive non-Hodgkin's lymphoma.
Well, give a few examples of aggressive lymphoma.
The diffuse large B-cell lymphoma, mantle cell lymphoma, which is the non-leukemic variant, classical mantle cell lymphoma, high-grade B-cell lymphomas, Burkitt's lymphomas, lymphoblastic lymphomas.
And
Then-
from the history, okay. From the history, what stage of lymphoma does it look like historically?
So it does look like a stage 3 advanced lymphoma.
So this patient had weight loss, right?
Yes,
You mentioned it was significant weight loss. So can you define significant weight loss?
So significant weight loss would be defined as a 10% loss of weight over 6 months. And this patient has had around a 10% weight loss in a probably a month. So it considered significant.
Okay. So what are the B symptoms? You will
B symptoms would
around. Yeah.
B symptoms would be presence of fever, which is not associated with any infection and which has been persistent for at least more than 2 weeks, and the presence of drenching night sweats, along with the loss of weight.
Significant loss of weight.
Significant.
So can you get these symptoms in other solid tumors apart from lymphoma? Any solid tumor which can produce these symptoms?
Yes, germ cell tumors can produce B symptoms.
Okay. If you don't consider lymphoma as a DD, what could be the DD? A solid tumor presenting like this in this gentleman, what would be your DD from germ cell tumor? Weight loss, multiple nodes. So what could be the DD you will consider based upon your previous experience or whatever experience you have?
I would consider germ cell tumors and also neuroendocrine tumors.
Neuroendocrine tumors.
Neuroendocrine carcinomas, small cell carcinomas of the lung I have seen with lymph
That can
nodes.
present like that can present like this. Okay.
Is there any suffix you want to use with the stage?
Sir, in this case, I would like to use a suffix 3B because significant loss of weight is there, but we don't know the histology. So
Is that still used?
it's not used, sir. It's only used for a Hodgkin's. If it's Hodgkin, we can mention 3B.
Shofij, anything else?
Nothing.
Or
I think
move
we-
to examination? Yes.
Yeah.
Sir, coming to general examination of this patient, he is ECOG performance status 1 and is moderately built. Height is 158 centimeter, weight 49 kilograms, BMI of 19.6 kilograms per meter square. His vitals, blood pressure is 130 by 80 over 80 in right upper limb in sitting position. Pulse rate is 81 per minute, regular rhythm, normal in volume and character. no pallor, icterus, cyanosis, clubbing, or pedal edema. Skin, there is no petechia, and there is no gum hypertrophy noted. And coming to the examination, he has multiple bilateral cervical nodes, which are non-tender, mobile, soft to firm in consistency, and it is not matted. And in the left cervical region, we have level 1B, 2, 3, 4, and 5 nodes. The largest is 3 into 3 centimeter node in level 2, and there is a supraclavicular, medial supraclavicular node 3 into 2 centimeter. And in the right cervical, we have level 2 and 5 nodes. The largest is 2 into 2 centimeter in level 2. Similar nature. Left axilla, that's a 2 into 2 centimeter node in the anterior group. Bilateral groin, there are multiple nodes, and the largest is 3 into 2 centimeter on left side. Similar nature. And tonsillar fossa is a right tonsillar enlargement, which is grade 2, not reaching the midline. And there is no epitrochlear, preauricular, or popliteal nodes. There is no testicular swelling noted. And there is no bone tenderness or sternal tenderness for this patient.
Wait, one slide back, please. Can you broadly, briefly tell about the levels of lymph nodes from stage 1 to 5, how they're divided?
Sir, level 1A is submental lymph nodes. Level 1B is submandibular. Level 2, you have the jugulo-digastric nodes, the upper cervical nodes. And those nodes are divided into level 2A and 2B. And level 3, you have the middle cervical. And upper cervical is level 4. Level 5 is posterior triangle nodes, and which is divided into level 5A and 5B. And level 6 is anterior nodes like pretracheal, prelaryngeal. Level 7 is retropharyngeal node.
That's fine, that's enough. Okay. When do you consider a lymphadenopathy as significant?
Sir, it depends on both the site of the node and the size of the node. In the cervical region, a lymph node of more than 1 centimeter and which is persistent would be considered as significant. And in axillary, it is more than 1.5 centimeters. And inguinal region, a node of more than 2 centimeter is considered significant. And in certain areas, nodes are considered significant, like epitrochlear, supraclavicular, popliteal, or a preauricular node.
Okay, go ahead.
Now coming to the a review of the systemic examination. And the abdomen on inspection, all quadrants move equally. There is not a dilated vein, scar, sinuses, umbilicus is central. The abdomen is scaphoid on inspection. No distension is there. Parabdominal examination, it is soft. There is no tenderness. The spleen is palpable, 3 centimeter below costal margin on inspiration. And there is no hepatomegaly, and bowel sounds are heard normally. On cardiovascular examination, there are no signs of heart failure. JVP is not elevated. S1, S2 heard normally. There is no murmur, no S3, S4. Respiratory exam, trachea central, no volume loss, and nervous system, high mental functions are normal. And there is no neurological deficit.
Okay. Let's summarize.
Sir, this is a 53-year-old male, diabetic with no habits like smoking, presenting with complaints of generalized lymphadenopathy for the past 2 months and significant loss of weight. On examination, we have found him to have bilateral cervical nodes, soft to firm and non-matted, and left axillary and bilateral inguinal lymphadenopathy, which is significant. And there is also mild splenomegaly is noted on abdomen examination.
Okay.
So,
Showfish, go ahead.
how do you classify splenomegaly mild, moderate, severe?
There is a Hackett scale for splenomegaly, and this, but it's a simpler clinical. This classification is less than 3 centimeters mild, 3 to 7 centimeters moderate splenomegaly, and which is short of the umbilicus, and more than 7 is massive splenomegaly.
Okay. So this patient had generalized lymphadenopathy, right? And how much was the BSA for this patient?
BSA was 1.446, sir. 1.46.
So what formula you have used to calculate BSA? Usually, what are the formulas used for calculation of BSA?
I have used a Mosteller formula,
Okay. What are the other formulas?
Du Bois formula.
Okay.
Um,
So molecular formula, can you elaborate just out of the question? But maybe sometimes examiners do ask these things. That's why.
height into weight by 3,600 and the whole root.
Okay. Fine. So yeah, this patient had generalized lymphadenopathy, right?
Yes,
So
sir.
if you want to do a lymph node biopsy, which group of lymph node you will prefer in this patient?
Probably I would take the biopsy from the largest node and the node which is in the supraclavicular region for this patient, because that is likely to have the highest yield.
So how much is the yield if you do a biopsy from this patient had a generalized lymphadenopathy?
Yes, sir.
So how much is the yield you can get the diagnosis if you do a from the inguinal, from the axilla, from the supraclavicular, percentage-wise, roughly?
Sir, in
Can
the
you
axilla, in the inguinal region, the yield may be low, around 25 to 30%.
Okay.
And in
Axilla?
the axilla, around 50%.
Yeah, 50 to 60%.
And supraclavicular, 65 to 80%.
Yeah, more than 90%, around 90% approximately. And the largest node you will biopsy, yeah? Will you be able to take out you want a incision biopsy or excision biopsy?
So ideally, I would like an excision biopsy because I'm suspecting lymphoma and the nodal architecture, and I would like to see on the morphology. So
if you do a lymph node biopsy from a larger node, will you be able to take it out fully? Or some other factors will guide?
sir, if it's a superficial node, we'll be able to take it out. And if it's mobile and not fixed to adjacent structures.
Okay, fine. Proceed. Dr.
So when you have a diagnosis that you're suspecting about lymphoma is predominantly a disease of the lymph node, but it can go into extranodal sites also. What
Yes.
are the extranodal sites commonly seen with NHL and in your clinical examination? How have you excluded them?
The common extranodal sites are the liver, spleen, CNS.
Spleen is not so much of an extranodal site.
It's a nodal site. It's a nodal. Liver, CNS involvement, pleural.
In your practice, which is the commonest extranodal lymphoma that you have seen? Most likely, it might be somewhere in the gastrointestinal tract.
Yes, sir. Yes, bowel.
Okay. Then you mentioned about liver, CNS, then GI tract, then
GI tract and kidney, breast, adrenal involvement,
bones.
testicular involvement, bone involvement.
Okay. Do you have any clue that this might have anything related to an extranodal lymphoma, extranodal presentation?
No, sir. As of now, I haven't found anything to suggest an
What
external.
might be the commonest presentation of a small intestinal lymphoma?
The small intestinal lymphoma usually presents with bowel obstructive symptoms like colic abdominal pain, and it is usually associated with the regional lymphadenopathy inside intra-abdominal lymph nodes.
Okay. What are the other known etiological agents or associated things that might be there with lymphomas? Any other infections or etc.? or any
In-
other diseases that could be associated?
Sir, in infection, HIV has an association with lymphoma, Epstein-Barr virus infection, HHV, herpes virus 8 infection. Then bacterial pathogens are like Chlamydia psittaci, Borrelia burgdorferi, and H. pylori. They are known to be associated with marginal zone lymphomas. And hepatitis C virus is associated with T cell splenic marginal zone lymphoma.
Okay.
And HTLV virus is associated with acute T cell ATLL leukemia.
Okay, go ahead.
In examination, did you mention regarding the? Can we go back to examination?
Yes, sir.
Systemic examination. Systemic examination, please. Okay. You forgot to mention about testis.
Yes, sir. I have mentioned in the general.
Exam. Okay, okay, fine.
Sir, so this patient was evaluated from an outside hospital, and they had already done a neck node biopsy, and it was referred to us. Unfortunately, we could not get the immunophenotyping of this patient. The patient was late to submit the blocks, and
So you will directly proceed with lymph node biopsy in this patient. How do you work for this patient?
Sir, before doing a diagnostic workup, I'd like to do basic investigations like a complete blood count and peripheral smear, and also creatinine, liver function test, and potassium, calcium, phosphorus, and uric acid and LDH for tumor lysis, and rule out coagulopathy, do a INR and prothrombin time, and then after that I would like to go for a tumor direct investigation and diagnostic investigation like a excision biopsy of the chosen
Viral
node.
markers you want to?
Yes, sir. I would like to do that before I give my treatments.
Before lymph node biopsy, you don't need a viral marker.
Yes, I will do. I would like to do.
So suppose this patient you mentioned came from another hospital. Suppose a physician there had performed an FNAC. And FNAC, they mentioned that there were some lymphocytes seen and tuberculosis could not be ruled out, etc., etc. What is the association between tuberculosis and lymphoma? Is there any higher chance of tuberculosis or any chance that tuberculosis might be associated with lymphomas? Because many a times lymphadenopathy might be misdiagnosed in the periphery as a tuberculosis. If suppose they come with a report of tuberculosis to you, what would you do?
So even if they do come with this clinical presentation, I would be prompted to take a excision biopsy of that node, because this kind of a presentation for a 53-year-old man with extrapulmonary tuberculosis without any immunosuppression and without any other features of fever or night fever or something is unusual.
Right. So the presentation is a bit unusual. He's not immunosuppressed. You should have always a high suspicion that there could be an underlying lymphoma, even though there might be a tuberculosis there. So sometimes you might need to start treatment for tuberculosis initially and then keep working up for lymphoma. And then if lymphoma is there, you have to go ahead with the treatment with lymphoma. Okay, next.
And it's always better to put DDs rather than putting a single diagnosis.
Yes, sir.
After examination and also after history, it's better to put DDs rather than putting one diagnosis. Because you have put only one diagnosis of lymphoma, so that everything will go into that direction. But if you have multiple DDs, that will be better. Okay. Any other DD apart from TB, lymphoma, any other diagnosis in this patient you would think about it, if you would place it?
Castleman's disease.
Okay. Anything else? The
And
disease in we will check calcium and serum leaders.
sarcoidosis, sir. Sarcoidosis.
Yeah.
Caseating.
Sometimes, yeah. Sarcoidosis is also a possibility. Sometimes some patients do present like this. So these are other diseases you can consider. So, okay,
Okay, go ahead.
fine.
And they had done an excision biopsy of the node and the morphological
So what
exam.
are the basic investigation in this patient? You
Sir,
didn't tell about the basic investigation.
Sir, I would like to do a complete blood count with peripheral smear.
No, the results are with you in this patient?
Yes, sir,
No.
the results are with me, and this is what the complete blood count showed. There was no anemia, there was no leukocytosis and or thrombocytopenia, and the routine blood chemistries we had done. RFT is normal. Serum LDH was elevated; it is 1020. Uric acid is 6.4, and there is no LFT alteration or transaminitis.
What are
ESR
the
was
other conditions you can get elevated LDH apart from lymphoma?
hemolytic anemia.
Okay.
Uh,
Anything else? If the patient has an
Myelomas.
anemia, ongoing fever,
Fever.
then any other conditions you can get elevated LDH. Well, LDH can be used as a tumor marker for which solid tumor? Malignancy.
Seminomas.
Seminomas. Okay. Apart from that, in any cancer staging, you use LDH as a marker.
Sir, in multiple myeloma, we use for high risk, we use LDH.
Other than that, in melanoma, sometimes we used to do LDH. In initial classifications, we used to do LDH. Any other infections in which where you can get elevated LDH?
Sir, leukemias.
No, any infections you can get elevated LDH.
Pneumocystis infection.
Yeah, PCP, pneumonias, you can get elevated LDH. And also sometimes if the patient has a HLH.
HLH, yes.
Also, yeah. Okay, good.
And sir, the routine investigations were normal, and the viral markers and the coagulation profile was normal. And we went ahead with the excision biopsy of the node. It was done and referred to us. And the microscopic section was showing in complete effacement of the nodal architecture by neoplasm arranged in diffuse sheets. There are intermediate to large cells with scant cytoplasm and the pleomorphic vesicular nuclei, and many showing prominent nucleoli, and which it has areas of necrosis and numerous mitotic figures, and it is infiltrating into the adjacent perinodal soft tissue. And they had given a provisional diagnosis of a non-Hodgkin's lymphoma, and we would further work it up with an immunohistochemistry for typing. And after this, I would like to do further staging workup. Also,
in your opinion, can you elaborate on the pathology, microscopy examination? What do you think about this description?
So this description, it shows, it does not show any follicular pattern, and it shows complete effacement of the architecture by sheets of neoplastic cells. And I feel that they are probably large cells, large B lymphocytes. And
why B? B leave it there, but this could
Ah.
be large cells without a follicular pattern.
Follicular pattern.
Quite a aggressive or intermediate to high grade lymphomas.
It
Okay.
needs further immunotyping to know the phenotype.
Okay.
So, yes.
Yeah.
Show fish, please.
Yeah. What panel of IHCs you will perform in this patient step by step? Can you elaborate?
Sir, in this patient, first I would like to, sir.
Come on this patient.
First, I would like to confirm the lineage. I would like to perform a CD45, and after that, CD20 for B cell.
CD45 will give you what answer? CD45?
That it is probably a hematological malignancy. And it just gives the lineage. And after that, I would like to do a B cell marker CD20, CD5, T cell markers CD3 and CD7, and then proceed from there.
Okay.
And if CD20 is positive and CD5 is negative, I would consider a diagnosis with this morphology, a diagnosis of a diffuse large B cell lymphoma, and I would try to find a cell of origin using any one of the algorithms like Hans algorithm. And if it is CD5 positive, I would consider the diagnosis of mantle cell versus CLL, and CLL is
a possibility in patient.
no sir.
Intermediate to last time.
No sir. With this presentation, I would not consider CLL. Mantle cell, though, I will consider, because
Okay. What is the marker for mantle cell?
cyclin D1, and this
if it is negative, what other marker you will perform? If cyclin D1 is negative, still you have SOX11. Okay.
And this patient.
Yeah, proceed. Tell.
No sir.
Proceed, man.
Okay, tell me, how did you differentiate the cell of origin?
Sir, we commonly use the CD. Use the Hans algorithm. I would first like to do the CD10, and CD10 is a germinal center marker. If CD10 is positive, it is classified into GCB, and if CD10 is negative, I would work it up with a BCL6. Next, BCL6, if it is positive, then MUM1, and if MUM1 is positive, it falls in non-GCB, and if MUM1 is negative, it falls in GCB again. And if both CD10 and BCL6 are negative, it falls in non-GCB, but then we will have to work up for other histologies like
Okay.
So how can you rule out a Burkitt lymphoma from a DLDCL? Clinical radiological and IS device.
pathologically, the Burkitt's lymphoma will have that smaller cells with large nucleus and scanty cytoplasm, giving the appearance of a starry sky appearance because of the necrosis and the gingival body macrophages. And morphologically, that will be that. And IHC wise, pathologically, I would do a CMIC for the patient with Burkitt, rule out Burkitt.
Only CMIC is needed for ruling out. In KA67 you want to?
Yes, KA67 also, sir. Burkitt lymphoma has a very high KA67, more than 90%, be close to 100.
Okay. Okay. BCL2, somebody else.
What are the genetic markers that might be beneficial to diagnose Burkitt's?
The translocation 814.
Any other translocations? Okay, go ahead, proceed.
Sir, after the immunophenotyping, and if we, after establishing a diagnosis of, after establishing the diagnosis, I would like to go for a staging investigation. And in this case, I will do a whole body PET CT And this patient, we had done the whole body PET CT, and it showed hypermetabolic high-grade lymph nodes.
In brief, multiple
Uh,
lymph nodes.
Disseminated lymph nodes on both sides of the diaphragm, bulky right palatine tonsil, bilateral renal lesions, omental nodules, multiple marrow-based lesions, which are likely lymphomatous involvement, some mild splenomegaly with diffuse hypermetabolism, and some splenic nodules were also there, suggestive of disease involvement.
Okay, so do you do a PET scan in all lymphomas, any lymphomas?
Sir, in PET avid lymphomas and aggressive lymphomas, we usually do a PET scan.
Which are the PET non-avid lymphomas?
Splenic marginal zone lymphoma, lymphoplasmacytic lymphoma, follicular lymphoma, grade 1, grade 2.
Follicular lymphomas, most of them might be just the marked lymphomas or the marginal zones, etc. might be PET non-avid. Okay. Any specific, like, is there any advantage of a contrast CT scan over PET scan in any situation?
Sir, there would be...
Practically, there might not be, but theoretically at least.
Theoretically, if the lesion is close to a critical anatomical structure, the contrast CT might be better in identifying the anatomy.
Especially things that might be in between intestines or very near to blood vessels, etc. Contrast CT might be beneficial. Okay, now suppose this diagnosis, go ahead, next.
Sir, after the PET scan, this patient, we would assess the fitness for chemotherapy.
Will you do bone marrow in this case?
In this case, the PET CT shows involvement of the bone marrow, so, and it's an advanced disease, so I would not do a bone marrow.
Okay. So, okay, then next.
Next, I would assess the fitness for treatment. I would take an electrocardiogram, 2D echocardiogram, and viral markers, including HBsAg, hepatitis B core antibody, total and IgM, HCV, HIV.
Would you do a CSF study for this patient?
Yes, sir. For this patient, CNS IPI is 4, so it comes in high risk. So I will do a CSF investigation.
What are the chances that the patient might have a CNS disease in CNS IPI is 4?
12 to 15%.
10 to 15%. Okay. So you did a CSF and you did not do a bone marrow. You did the PET scan and you did this thing and you assessed the patient's fitness for chemotherapy.
Yes, sir.
Okay. What next slide? Any more slides?
No, sir.
Okay. What type of treatment are you going to advise to the patient?
Sir, he is a
so suppose the diagnosis is DLBCL, DLBCL non-GCB type.
Sir, he is a fit 53-year-old with a non-GCB type DLBCL. For this patient, and he has CNS high IPI score. For this patient, I would suggest chemoimmunotherapy with R-CHOP with CNS prophylaxis in the form of...
Why do you want to add R-CHOP? Why not only CHOP?
Sir, rituximab has a survival advantage. And
what survival? PFS or OS or both?
Both is there, sir. Both
Which
is
study?
there. And we have data from the GILA trial and MapThera international trial.
Okay. MINT trial. Okay.
MINT trial.
So R-CHOP with?
R-CHOP with intrathecal methotrexate. We follow at institute R-CHOP with intrathecal methotrexate, and we follow the high dose methotrexate after the completion of 6 cycles of chemotherapy. I would also do a interim assessment with a CT after 3 to 4 cycles of chemotherapy.
So does this patient have any bulky area?
This patient does not have any bulky areas.
Any high risk adverse risk factors?
adverse risk factors are the stage 4 disease, high LDH, bone marrow involvement, and high CNS risk.
Okay. Okay. So you're going to plan for 6 cycles and with an interim PET.
Yes.
How does you are going to justify in terms of doing an interim PET in this case? Will you alter your management after 4 cycles? Is there a guideline to do an interim PET in the LDCL?
No, sir. As such, it won't alter my management in advanced stage disease. CT is sufficient.
Then why you want to do it? Then why you want to do if the patient is having a clinically responding disease? Why you want to do an interim PET in DLBCL? You see, you are clinically the patient responding, nodes are regressing, and he is doing well. Then why you want to do interim PET? And if it won't alter your management,
It is a surrogate for the progression-free survival, which I will get. The IPET-4 has been shown to correlate with the PFS at 2 years.
So it has
Okay,
got a
so-
prognostic value, but it's not going to change your management.
No, sir, it's not.
Which
going
other
to.
lymphomas, in which other lymphomas might an interim PET help in changing the management?
Sir, in Hodgkin's lymphoma, we do response adapted treatment.
Any other? What about DLBCL with no adverse risk factors?
Sir, in very early stage DLBCL without any bulk or high risk factors like IPI score less than 1. In that cases, we can do an interim PET-CT, and 4 cycles of R-CHOP may be enough, or 3 R-CHOP plus RT may be enough.
Okay. So this you're planning for 6 cycles of R-CHOP, and you're doing a 3 at the and with every cycle you're going to do an IT methotrexate.
Yes, sir.
And at the end of the treatment, you're going to give high-dose methotrexate.
2 cycles of high-dose methotrexate, sir.
Any other alternate ways of giving CNS prophylaxis?
High-dose methotrexate can be interdigitated between the cycles of chemotherapy.
What are the dose of high-dose methotrexate?
We typically use high-dose methotrexate at 3 grams per meter square, and it's given as an infusion over 4 hours.
And what are the precautions you will take for high-dose methotrexate?
And the precautions I will take is I will maintain hydration and alkalinization. I need a urine pH of more than 7.5 and a steady urine output of more than 100 ml per hour. And this is to prevent kidney injury and methotrexate toxicity. I would also ensure to look at electrolyte imbalances like hypokalemia. And also I would institute look over and rescue 24 hours after the methotrexate, and it should be methotrexate levels will be measured at 24, 48, 60 hours. Every 24 hours it will be measured. And the look over
after starting methotrexate, within 12 to 24 hours, the patient's ALT went from 34 to 180. What would you do?
Sir, we finished the methotrexate. So I would.
Are you much concerned about enzyme elevations in methotrexate?
No, sir. Usually they are transient.
Okay. So we did an interim PET for this patient, and the PET was showing what? What do you want? Suppose it was showing a Duvalli score of 3. What is a Duvalli score?
Duvalli score is basically to standardize the PET reporting, and it is a visual impression of the uptake values, and it's graded into 5 categories. You have dual 1, there is no abnormal FDG uptake. Dual 2 is less than mediastinum. Dual 3 is more than mediastinum and less than liver. Dual 4 is slightly more than the liver, and dual 5 is markedly more than the liver. And in the interim PET-CT, if it is a dual 1, 2, or 3, I will be happy.
And you will continue. Shaufij, anything?
can you tell the dose of R-CHOP?
R-CHOP is dosed at rituximab 375 milligrams per meter square, cyclophosphamide 750 milligrams per meter square, doxorubicin 50 milligrams per meter square, vincristine 1.4 milligram per meter square, prednisolone at 60 milligram per meter square, day 1 to day 5.
Okay. So, what will be the cost of R-CHOP in your center per cycle?
So it will be around 50,000.
50,000 per cycle in your center in MBR. Are you sure? How much is the cost for this one, rituximab 500 mg? Now, a lot of biosimilars are available. So, what is biosimilar versus generic? Or what is the difference? Biosimilars.
Biosimilars are reverse
How does
engineered.
How does it different from generic? Cost is 50,000 in your center. R-CHOP. Sure. Have you looked at the bills?
Sir, I'm not sure, sir.
Okay. Fine.
Just now you heard Dr. Nasrin talking about polatuzumab vedotin. What will you replace in this? If you are given an option to use that, what would be the regime like?
I would replace vincristine with polatuzumab, and it will be RCH polatuzumab.
Any alternatives for rituximab?
There is an alternative, obinutuzumab, and it is a type 2 glycoengineered antibody, and which has more affinity and it is more potent to the CD20.
What is the prognosis that you'll tell to the patient's bystanders regarding this stage, this patient?
This patient has an high intermediate ITS score. I would explain to them that they have around a 60% chance of a 3-year PFS and a 60% chance of cure.
Suppose the patient relapses after 2 years. After getting a CR, the patient relapsed after 2 years. What would you do?
Sir, a relapse after 2 years, it shows a favorable biology. I would like to do give a salvage give rebiopsy, reconfirm the diagnosis, stage it, and give salvage with this is a non-GCB type, so RDAP or RICE.
If
or
the
RGD.
patient can afford anything? Okay. Now, suppose this patient was asymptomatic. He was not having any B symptoms, no symptom. He accidentally saw that some lymph node swellings were here and there. And the biopsy came as follicular lymphoma grade 3A. How would you manage?
So if it's a follicular lymphoma grade 3A, I would see if there is any indication to start treatment emergently, like presence of any bulky disease more than 7 centimeter, or presence of more than 3 sites of disease, each more than or equal to 3 centimeter, presence of any organ compromise, serositis or effusions, any cytopenias, persistent recurrent B symptoms which are not responding to treatment, which are not supporting care, and then decide on treatment based on the indication.
If there is no indication, none of these factors, then
Watchful waiting. I would do watchful waiting, and as and when the patient develops a symptom. But if the PET CT, in this case, if the PET CT shows marrow involvement and such burden of disease, I would not expect that he would be asymptomatic for long. So I would counsel him for treatment.
what is the best prognostic indicator of, Shafi?
What is composite lymphoma, man? Composite lymphoma.
Composite lymphoma is when you can have two different clones, like there may be a follicular lymphoma coexisting with the DLBCL.
So if you got a diagnosis of follicular lymphoma grade 3A from one side, how will you rule out a composite lymphoma in such a patient while doing a watchful watching? Practically, how do you decide?
I will have to rebiopsy from the progressing side.
From the
progressing side.
progressing side.
Um,
Okay.
Based on petability, I'll
Yeah,
have to do that.
Flexibility, maximum uptake site, you have to do
Maximum.
biopsy.
Biopsy.
That will give you an answer, right? Practically, you can do that. There is no guidelines, but that's how we all do. Okay.
My last question from my side. Suppose it was a follicular lymphoma and it required treatment. What is the regime that you would choose?
Sir, I would choose a BR regimen.
How many cycles?
6 cycles of bendamustine rituximab.
And followed by?
Followed by no maintenance.
Why?
Because in
Not a fan
follicular,
of maintenance.
the maintenance is with R-CHOP, then followed by maintenance, we have the PRIMA trial. But post-BR maintenance, we only have data for mantle cell lymphoma. We don't have
for R-CHOP, would you use a maintenance?
R-CHOP, I would use a maintenance in this case because the patient has a high burden of disease. And it will
What is the
benefit.
advantage of a maintenance?
Sir, at 5 years, at 10 years, probably a 20% difference in PFS will be there with maintenance.
And OS?
So there will be no overall survival benefit.
Toxicity?
Toxicity, we can expect more immunosuppression, more infections.
3 times more infection. Grade 3-4 toxicity is almost 60% more than placebo. You want to still give a maintenance?
I would like to maximize the DFS.
Okay. Thank you. Shaufij?
Nothing else, sir. I think we will wind up already 8:45. He must have exhausted. Arun, can we wind up or you
Yeah,
need more?
I think it's time. Anyway, I think Dr. Ashwin has done tremendously well according to opinion. I think Dr. Sunu and Dr. Shaufij, are you happy with the presentation? You're the examiners. You can give a final comment. Pass.
Yes, I think his answers were crisp and nicely replied. I think pass definitely a good score also is rewarded.
Question of gold medal or not, right? Okay, we'll have to see. Anyway, yeah. So thank you to the examiners. Yeah, that was very detailed. Yeah, and yeah, I think a very detailed examination of lymphoma per se. So a lot of learning points there. Again, I've learned some new other things also. So it's the pace to attend this as well. So I think, yeah, we'll wrap it up for today. And we've had a decent attendance. I think more than 60 people are logged in. And next month, I will share the details on the group. So I'd like to thank both the presenters once again and both the examiners also. Over to Dr. Bobbin, if he's here for the final comment.
Yeah, it was a very good case presentation. So I just very good questions, and Dr. Ashwin did a very good job. I was wondering, like, even at that stage, I wouldn't be answering even 25%. A good job. Keep reading and come up with good colors in your final exam. So that's it. So no further comments. So we'll wind off the session and we'll meet next month. Thank you. Thank you.
Thank you.
Thank you.
Thank you, sir.